Perfecto. Okay. All right. Good afternoon, everyone. Thank you all for attending our webinar on Medication Basics Part 1. Just a little bit of housekeeping before I introduce our speaker. Later after the talk, we will have question and answer portion. And so below if you're using your computer for Zoom, at the bar below, you will see a Q&A part. There's also a chat portion. So you can use either one. I'm going to be monitoring them and let Dr. Kehoe know at the end of the presentation about our questions in the Q&A and the chat. If you're using your phone, usually it's on the below bar also, but you have to tap it first to make it appear. And then if it's not appearing there, usually there's also a 3 dots. And if you click that, it'll show you more options, and that's where you can find the Q&A and the chat portion of your Zoom, basically. So we really appreciate you all for attending. This will be recorded. This is being recorded right now as a webinar, and then the recording, once Zoom sends me the link, we will have it posted in our website and also our social media page. For you to get credit for your CEs, those who are interested in having CEs, you would have to contact Lorraine Rodriguez. And I'm sure you have received also an email reminder that has her email there. So send her an email saying that you wanted to receive CEs because you've attended the Medication Basics Part 1, and she will send you back a copy of the quiz. When you return the quiz to her, then she will send you back the certificate. Okay? I will now move you over to, and for those of you who wanted to know, Lorraine is also here. Lorraine, I'd like to let you say hi for a short time.
Hi.
Okay, thank you, Lorraine. Lorraine is our senior office technician helping us with all our classes. And for our speaker, without further ado, I will give you all over to Dr. William Kehoe.
Hi, good afternoon. And let me also tell you how much I appreciate everyone attending this. It's our first Zoom experience with the medication classes at VMRC. This has taken the place of our normal Wednesday or Thursday classes during the pandemic, since we can't meet with you. So this is my first Zoom presentation. I've attended I don't know how many Zoom meetings over the last 6 months, but this is my first PowerPoint Zoom presentation. So I'd appreciate feedback from you if you have pointers for me. So as Dr. Lazaro said, this is Med Basics 1. We'll follow up next month with Med Basics 2. A lot of this material is based on my own experience, but also information from the state for DSP training. I would look at today's material as really to your medication system process in your facility. And so the idea today is just to simply increase your skills in how to assist consumers who are taking medications while they're in your care. We want to talk about safe practices, but also things that I think will help optimize the chance for these medications to be effective in our consumers. We'll spend a lot of time talking about documentation. I review all of the medication-related incident reports that come into VMRC, and some of what I'm going to tell you is based on what I've seen in those SIRs. And what we're trying to do is to look at SIRs, categorize them, and then develop educational interventions that will hopefully reduce those kinds of errors in the future. So after you attend this presentation today, I'm going to talk a little bit, I'm going to throw some vocabulary terms out at you. I'll try to not use jargon without defining what it is. talk with you about prescription labels. There's a lot of information on the label, but also many of the medication errors that we have could probably be prevented simply by using the label as you're helping to administer the medication. We'll talk about the 7 rights, and I want to qualify this. This has gone from 5 rights to 6 rights to 7 rights, and probably in the next year we'll get up to 8 or 10 rights of medication administration. I'm going to highlight from that list for you the things that I think are really critical when you're getting ready to help a consumer take medications. We'll talk about storage and also the medication administration process and documentation. And then we'll talk about strategies that you can use when consumers refuse medications. We do find that to be a problem. They have the right, just like you and I, to take or not take their medications. And so I'm going to give you some pointers on things that you can do to actually help them, hopefully to not refuse. All right, let's talk about medications. And I would preface this by saying later on, there'll be modules where we talk specifically about medications for certain disorders. We have a module on antipsychotic medications and what they're used for. We have a module on epilepsy and seizure disorders and the anticonvulsants. So if you keep up with this series, you'll find that we do have times where we give more specific information about medications. But I'm going to talk to you more in generalities today, things that I think you should know when you're assisting our consumers. So what are some really basic things? Well, what's in the name? I'll talk with you more about that in a moment, but medications have both generic and brand names, and there can be more than one brand of a generic name. So I find in my own experience, I prefer to talk about generics because there's only one generic name for a drug, whereas you might have 1, 2, 3, or 4 more brand names. I'm going to talk with you a little bit about knowing what a medication is used for. I'm going to give you some websites that you can go to, whether it's on your phone or on your computer, that are trusted drug information sites that you can actually do a quick read on medications and find out what it's used for. But we're not expecting you to be prescribers or pharmacologists at this point. Really important is how is it to be given? Again, there's many ways. I'll talk about the ways that we have of getting medications into the body, but we're pretty good at doing it, and it's not all just oral. But also knowing the conditions to give the drug. For instance, on an empty stomach, does it need to be taken with food? Those kinds of things. Another critical issue in this population, or any population that's in long-term care, is what is the duration? How long is it going to be used for? If you go back 20 or 30 or more years, you'll find that folks who are in care facilities, whether it's a long-term care, skilled nursing, or whatever, would end up on these long lists of medications, particularly the as needed or what we call PRN medications. They'll end up on this long list, and there'll be some that were given for a short time because maybe they had pain or something, and it gets added to the list. It would be left on there. And so regulators came along and said, well, wait a minute, this is crazy. We got people with 20 medications or more on this list, and some of them are not needed. And a part of that is not knowing and watching the duration that was intended the medication to be used for. Other things like, as I said, giving with food or not, should know something about side effects. Again, I'll give you some references that you can have on your phone or on your computer where you can take a quick look if you want to see if you're giving a patient, for instance, Depakote, or even if you're taking Depakote, you can look this up quickly and you can find what common side effects are. Lastly, a little bit about drug interactions, although I would qualify and say, I don't expect you to know many interactions. There's probably 1 million out there, and I certainly don't know all the drug interactions, but I know how to find out. And that's one of the things I want to help you with today. All right, so let's talk about a name. Again, you have drugs and they all have a generic name. And that is what a name is given to it when a drug company invents and develops the medication. Then that company gets to name it. And they have various ways of doing that. They have panels of people that they bounce names off of. And I'll tell you this, that as time goes on, some of the newer brand names, I can't even pronounce anymore. They're just crazy. but somehow they come up with these brand names. And so there can be many brand names, but for each drug, there is one generic name. And so that will always work. So let me give you an example. Something that I see our consumers taking, for instance, might be the antipsychotic risperidone. Now, the risperidone is the generic name. It is made by a company named Janssen, and their brand name of it is Risperdal. So sometimes the brand names are a little catchier, they're a little easier to remember and say, and so you might hear me talking about Risperdal when in fact the patient might be taking a generic risperidone made by another company. So that's the difference between brand and generic. And you almost always see on your prescription vials, in fact, I think you'll always see the generic name. Most of us, kind of as a little sidetrack here, if you're interested, let me give you my take on generics. As a pharmacist, I get a lot of questions from patients about, should I take a generic or should I demand the brand name? Well, there are some things that come into play here. You may or may not be able to demand the brand name. Branded products typically are more expensive, particularly 2 or 3 or 4 years or more after the drug has come off patent. A drug company gets to patent a drug for a certain period of time. When it comes off patent, then other companies can make that generic. And so at that point, people will say, well, should I get the generic or the brand? Almost always your insurance company is going to pay for the generic. And if you want the brand, you're gonna have to pay a higher copay, or it's gonna be a tiered system. The bottom line is that my family takes generics and I'm very comfortable with those. There are some specific instances, possibly certain kinds of anticonvulsants for seizure control. There's been some conversation about brand versus generic in that situation. Nevertheless, many people still take the generics. So that's kind of my take on that. I'm very comfortable. Personally, I take, my prescriptions are all generic. So the reason you need to understand these names is so that you can compare what's on the prescription and the container to what is on your medication administration record, or what we call the MAR, so that there's no confusion and there's no mistaking things. You always want to make sure that the name matches what they're supposed to be getting. Now, what is meant by quote unquote indication for a medication? The drug companies take these medications through clinical trials for specific reasons. We call those reasons indication. So for instance, let's talk about blood pressure or hypertension, high blood pressure. A company might take a medication through clinical trials, testing it in people who have high blood pressure. They find it works and it's approved and brought to market. The FDA will approve that medication for the treatment of hypertension. Now let's say that they decide to test it for another indication. Maybe, well, for instance, clonidine was one that was introduced for blood pressure, and we later found that it helped children with ADHD. And so clonidine actually was tested and found to be effective for ADHD. So that's another approved indication. Now, drugs can have other reasons that physicians or prescribers use them that are not FDA labeled indications, and those are called off-label uses. And that is where we have a reason to think a medication might do something for us in an area where it really hasn't had these large clinical trials. And with experience, we find that it does work for that situation. And it becomes standard, what we call standard of the practice in that community of specialists. And so medications can be used in what's called an off-label fashion. The bottom line for us who take care of consumers is that for a drug, we need to know, are we giving it for the right reason, and is it in the right dosing? Now, I don't, as I said, I don't expect you to be prescribers, but I would expect you to take a quick look at patients' medications and be able to know this drug is probably for this kind of situation. Here's some reason, is this a reasonable dose or whatever? But again, I'm not expecting you to be the prescriber on this. I'm just saying it's a good idea to know what they're for. And why do I say that? Because if you know, for instance, we're using Risperdal and we're using it for psychotic behavior, you're the frontline people caring for our consumers. You can tell us if the psychosis is getting better or if it's not getting better. simply by knowing that the risperidone is being used for that indication. So again, if you have any questions on why patients are getting medications, look at their their list of health problems, get some idea of which drugs are being used for which conditions. Now, how should it be given? Okay, there's a lot of ways besides putting a drug in a person's mouth to get it into the system. The idea is we want it absorbed from somewhere to get into the systemic blood circulation. So obviously the most common route of administration is oral. And we have a number of preparations that can be used in that situation: tablets, capsules, liquids, elixirs, orally dissolving tablets. There are a number of things that we can put in the mouth and get it into the body. There are a lot of drugs that are inhaled into the lungs, particularly those that are used for asthma and COPD. There are some medications that are only injected. And right now, the insulin that you're using is going to be injected. They're working on intranasal insulin and inhaled insulin and things, but right now, you're probably giving insulin and it's going to be injected. There are medications that we can give rectally, the mucosa of the rectum, there's a lot of circulation there, and we can give suppositories to get medications in. That's one way that we can help patients who can't swallow large tablets in certain instances. There are a number of medications that are dissolved either on the tongue or under the tongue or next to the cheek. And those are usually referred to as orally disintegrating type of tablets. And then obviously we can put things on the skin, and not for just for things like rashes, but we can put things on the skin to help with other conditions. So for instance, there are estrogen patches that we use topically. So the reason I tell you this is that it may not always be obvious from the preparation how we're actually going to use it. So when we talk about dosage form, then we're talking about what is it? It's a tablet, it's a capsule, it's a liquid. There are nasal sprays, there's powders, there's all kinds of ways that pharmacists have of getting medications into a formulation or a dosage form that will allow the medication to get into the body. And then today, as opposed to say a long time ago when I was a kid, which is a very long time ago, pharmacists used to what we call compound a lot of medications. And that kind of went away for a while because manufacturers typically now make those dosage forms, and very few physicians are going to ask us to actually make a dosage form. But you also know that today there are compounding pharmacies out there that can take formulas that physicians want and then make them properly into an appropriate dosage form that can be used. And those are called compounding pharmacies. And we do have some consumers who get medications from a pharmacy that will do those compounding things. So other things to think about, medications are given for different periods of time. Now for chronic conditions like high blood pressure, schizophrenia, those kinds of things that are going to probably be with us lifelong and require medications, those chronic conditions, those medications are going to be given for a very long period of time. There are other situations, for instance, you get an infection. Let's say you have an upper respiratory bacterial infection. Perhaps we give you antibiotics, maybe amoxicillin or something like that, and we give it to you for 10 to 14 days, sometimes less, fewer days. Or you have a urinary tract infection, we typically treat those for 3 to 5 days, depending on which medication we're using. So the important point here is for us taking care of consumers is to know what is this being given for, and is it for a time-limited thing? Most often I see this as a problem with our as-needed or PRN medication. So for instance, let's say one of the consumers you're caring for falls and hurts himself. Well, maybe he's going to be given an analgesic medication because of that fall and the trauma. Maybe he has a sore leg or whatever. Well, you want to ask yourself the question, when that trauma heals and the leg is no longer sore, does the person still need that medication on his profile? And that's where you would want to ask the prescriber, to review the medications and see if there are any of those PRN medications that can possibly be eliminated. Now, many of our consumers do have PRN medications on their profile that probably should stay there for PRN reasons, because occasionally maybe they get constipated occasionally. So they've got a DocuState prescription PRN constipation. Or maybe they have some musculoskeletal thing that flares up occasionally, and they need an analgesic. In those situations, it's okay. The point is the condition that the PRN medication is for, is it ongoing and does it keep happening, or was it resolved? If it's resolved, then maybe they don't need that medication on there any longer. Now, another question I often get from patients is, should I take this with a meal or on an empty stomach? And again, it depends on the medication. Some medications have to be given with food in order to be absorbed appropriately. And a good example of that is a drug, the brand name Geodon, which generically is ziprasidone. It's an antipsychotic medication. And it actually requires some of the fat that you get in a meal to be absorbed in appropriate concentrations. Another drug that you should not take on an empty stomach, and that is brand name Advil, or which is ibuprofen, which is an example of a non-steroidal anti-inflammatory drug, or NSAID. You should always take those with food because they actually reduce the mucosal defense mechanisms in your GI tract against acid erosion. So, you know, if you're taking any of those non-prescription NSAID type drugs, ibuprofen or naproxen, take it with food. There are other things that have to be taken on an empty stomach in order to have good absorption. For the majority of drugs, it really doesn't matter. So how can you know? Pharmacists will always put what we call an auxiliary sticker on the prescription bottle. I'm going to show you an example of that in a few moments. But if there's a specific condition that's required for the medication, there will be a sticker on there to tell you. Okay, so bottom line is always, if you're confused or you have any questions about that, you can always call the pharmacy and ask them how to give this medication properly. Like I said, for some, it really is critical. For most, it's not. But if you're talking about a drug like ziprasidone, in my view, it's critical that it be taken with a meal of about 400 to 500 calories. Now, what do we mean about side effects of medications? Well, it means an undesirable effect. So now you can look up a medication on one of these websites that I've told you about, or will tell you about how to find, and you can see what the common side effects are. But one thing I always remember is each of us is an individual. Each of us will respond to medications in different ways. And so I always listen to my patients. I never blow off something that they tell me might be happening because of their medication, just because I've never seen it before, or just because it's not on the list of common side effects for the medication. So I never blow this off. I always try to find out what's going on. But the fact of the matter is that, for instance, in any given week, you and I may have a headache. You and I may have an upset stomach. Stuff just happens to us. And sometimes if we're taking a medication, just because it's in that time frame, we may blame that on the medication when in fact the upset stomach might have just happened because you ate too big of a burrito last night or something, as I did last night. So, I mean, you never really know. So you have to pay attention to these things. So I would say one of the things you can do is to review your medications occasionally. Just take a few moments and look at those medications and look them up on one of these resources I give you and just get an idea. But also, here's a really good thing to do. Every time you and I get a prescription at our pharmacy now, they give us paperwork for that medication. Most of us look at it, tear off the receipt and keep it and toss the rest or whatever. Those things are ready-made drug information sheets for you, and they will have the common side effects listed there. They will also have serious side effects that are uncommon. Serious. So one of the things you might do is create in your facility one of those expandable file folder things, and you could keep just those sheets just in that file folder thing for your consumers, so you can do a quick look at what their medications might be causing. If you do think your consumer is having a side effect, you want to document that and be specific in what you think you're seeing. You want to let the prescriber or the physician know about it. And then it's a good idea to let us know at VMRC. I get emails all the time. By the way, my email is pharmacist@vmrc.net, and I can answer questions. You can go through your service coordinator. We can take a look at a list of medications, and I can give you an idea. Is this what's happening with my consumer? That resource is there available to you. The important point is make sure you document and tell somebody what you think might be going on. Now, just a brief thing about drug interactions, because again, if I were you, I probably would not go to the internet and load up one of these drug interaction checkers, because there are so many interactions and they have to be interpreted whether they're really serious or they're not serious. But drugs can interact with each other, and they can interact with food substances. They can also have what we call drug disease interactions. There's certain things like, for instance, drugs we call beta blockers. If a person with asthma takes a beta blocker, they might bronchoconstrict on you, and that's a side effect. And that would be an example of a drug disease interaction. These should all be and will be assessed by your physician, but many of our consumers have more than one physician, and very often they may or may not have the complete list of medications. That's why I always recommend for everybody, not just consumers, you should really have one pharmacy that you get your prescriptions from, because that will mean that they have a profile with all the consumers' medications on it, and they will do these drug interaction checks. Every time they pull up to either fill a new prescription or do a refill, the computer will flag us and tell us if there's something that we need to look at. So the bottom line here is, if your consumer has a long list and you have any questions, you can call the pharmacy. If you have a long list of medications, you should talk to your pharmacy and know what interactions might exist. Lastly, I would point out that just because medications are available over the counter or OTC without a prescription doesn't mean they don't have interactions. You should always check before you take an OTC medication against your personal list of medications and make sure that there are no interactions with what you're taking. All right, what's on a prescription label? Okay, those have gone from looking pretty simple. I have one, I don't know why I kept this, but I have a prescription vial of my aunt's, I don't know, from maybe 40 years ago or something. I keep pharmacy things because I'm a pharmacist, but anyway, it's just so straightforward. It's like, got her name, it's got the name of the drug and the date, boom, out the door. That would never happen today. Both state and federal law have regulations about what must be provided in the way of label information to patients. But as a care provider, you should be able to look at a drug label and have some idea of the information that's on there. So I have this, but today prescription labels have gotten very busy. And in some situations, I find my own prescriptions, I have a hard time reading because the font is a little bit small. Believe it or not, the state of California, the Board of Pharmacy, actually has regulations about font size to try and deal with that issue. But there's a large amount of information. Obviously, you have the name of the pharmacy, where they are, and how to get a hold of the pharmacy by phone. Then you'll have information, generally always on the label, information about who prescribed it. And you'll see that on there, Dr. John Schulte's. And there'll be an RX number. Now that RX number is critical because that's what you're going to want to give the pharmacy when you call in a refill. It's not just, hey, I want to get a refill of my atorvastatin tablets. I mean, that might be part of it, but generally they will ask you for your prescription number because that is a specific number for that prescription. And if you get a new prescription for atorvastatin, you will get a new RX number. We also have to have the patient name on there, obviously, and the date that we filled it. Now the directions, there's also specific regulations on the directions. And sometimes, a long time ago, we might say, we'll take one tablet a day. And now the standard practice is to take one tablet by mouth. So you'll generally see actually how to take it in those instructions. You'll then see what the medication is. You'll see this prescriptions for atorvastatin, and that is the generic name for a cholesterol reducing agent. And you'll see the strength and you'll see the form. It's in a tablet form. That little name below it, Watson, is actually the generic manufacturer. That's important to know because sometimes something will go wrong with medications in the production process and there will be a recall of those medications, and it might be for a specific brand. So that's why it's important for us to record and remember which brand of generic that we gave you so we can deal with recalls. You'll also see on the label how many are in the bottle. That's very handy because if you're like me, you might forget sometimes, did I take my blood pressure medicine last night or not? And I can always, pour it out, count the tablets. I started with 30. It's 5 days since I got it. There should probably be 25 left. Oops, there's 27. So I forgot to take it for a couple of nights. But that's really important. And then also you'll notice how many refills are left on there. Now this is critical for our consumers because one of the common errors I see is that consumers run out of medications and the refills haven't been delivered yet. Okay, there's a lot that goes into the refill process. It's not a simple matter of just calling the pharmacy, except in this situation, it would be, you don't have to give them as long a notice because the physician or prescriber has already said there's 2 more refills on this medication. If you see 0 on there, that means they're gonna have to contact the physician's office again, and that can take time. So my recommendation is to keep track of when your consumers are going to need refills. Make some notes, make a list or whatever it is, so that you can be on top. Claire, am I back on there?
You're back.
Okay, let's see if I can you still see my
Yeah, your presentation disappeared.
Okay, let me see if I can bring it back. I think that I'm having internet connection issues. Can you see it yet? Oh, wait, share. Now can you see it?
Yes, we see it. You just have to
You see it?
maximize your screen. Click the green.
Yeah, I'll bring it back.
Okay, thank you.
Okay, I'm getting an internet instability message. I'll try and hurry. So I don't really So anyway, I was saying about the refills, it's very critical that you know when and that you give your pharmacy about 5 to 7 days lead time to get those refills. Okay, now we get into the famous rights of administration. As I said, there were 5 and then there were 6. And now the latest version is 7. Basically, it's to protect the consumer from us making a mistake on the consumer's medication. So is it the right person? Is it the right medication, the right dose, the right time, the right route of administration, the right reason, and make sure that you do the right documentation. So in terms of the right person, you want to confirm you have the right consumer. Most of us will know that because you're working in a facility and you know them. In the hospital, if you go to the hospital, you're going to see them ask you your name and your birthday. We use 2 identifiers in the hospital. The idea there is to make sure you're working with the right consumer. Believe it or not, I see SIRs where consumers have been given somebody else's medication. Okay, you can stop that by making sure you have the right consumer. You compare their name to the name on the bottle that you're taking the medication from, and you compare that to the medication administration record. Those checkpoints will keep you from making mistakes. Is it the right medication? Do I have the right prescription? So you compare the label of the prescription on the medication administration record, the MAR. And then you look at the dosage form, and then you, if anything looks different, then you need to stop and figure out what's going on. Why is it different? Did I pick up the wrong bottle? Is this an old prescription this patient had that wasn't removed from his storage? Those kinds of things need to be squared away before you give the medication. Right dose. Now, you're not going to be deciding how much risperidone am I going to give for psychosis. That's not what I'm saying here. But it means the amount of medication. And one of the common errors that I see is sometimes we're going to give 2 tablets to make the total dose. They'll say, risperidone 4 milligrams at bedtime. And what that means is maybe the prescription's for 2 milligram tablets. That means they take 2 of the 2 milligram. That should be on the MAR. and it should be very specific about how many dosage units are required to make up that dose. So you always check the label and the MAR to what you're about to give. And so be careful, because medications are available in a number of strengths. And sometimes you'll see multiple tablets or capsules having to be given to make the dose. So always make sure you check that bottle and the MAR before you give it. Now, another thing that happens is the timing of the dose. For most of the medications, to be totally honest with you, that our consumers are taking, they're not what I would consider to be time critical. So an example of that, for instance, some medications, a prescriber might write, take 1 tablet 4 times a day. So the question I get, does that mean every 6 hours? So there's 24 hours in a day. Generally, when a prescriber writes, take it 4 times a day, they don't mean get up in the middle of the night, write it 6 hours and take it. They mean take it basically spaced out as close to 6 hours apart during the day as you can, but it's not time critical. If they want it to be time critical, they will say take 1 tablet every 6 hours. And in general, that's how we tell the difference on criticality. But to be totally honest with you, for most of the drugs our consumers are taking, an hour difference here or there is probably not going to make a difference. So for instance, you might have a policy at your facility that says, take a drug once every morning. Okay, well, does that mean 7 a.m., 8 a.m., or 9 a.m.? If it doesn't matter about meals, then you can probably set that up really however you want, whatever your facility policy is. And so you try to give them as close to what the time is on the MAR as possible. And for some drugs, that's very important. For most, it's probably not. So a general rule is to try and give the medication within 30 minutes to an hour on either side of the due time. Now, your facility might have a policy that talks about that, but the idea there is to try and get as close to the time when it's due as possible. I do see missed doses. Maybe a drug's given twice a day and the morning dose is missed. And in that situation, you can always call the pharmacy and ask them, you know, what's to be expected from a missed dose? What should I do? And the pharmacist will generally be able to tell you, oh, just start it over again with that second dose of the day and move forward. We generally don't recommend doubling up on doses very close together if something is missed. But again, your pharmacist or your prescriber can help you with that. And again, we talked about the route of administration. So again, making sure you know, and again, it's not always immediately obvious. There used to be some capsules with powder that we put in these little inhaler devices that punctured it and you inhale the dry powder. And some people were taking the capsules orally to stop their wheezing, and that was not the way to use the thing. So always make sure that you understand what the route of administration is and what does that really mean. Now, for the right reason, what we meant is talking about those indications that I was talking with you about. And again, it's just understanding, why are these medications in general being used? You may not know in every situation because, as I said, prescribers might use something in an off-label fashion. Where it is critical is on the PRN medications. Those always have a reason to be given. It will say, for instance, if you've got a patient who's, let's say, taking Norco, it might be 1 tablet every 6 hours as needed. And then, well, as needed for what? Well, it's as needed for pain. Physicians should never write just PRN and leave it. We call it a dangling PRN. There should always be a reason there, and the pharmacy will almost always, or should always, call and find out what the reason is. And the reason I say that is when you give a PRN medication, then you need to do some follow-up and find out if it worked for the reason that it was being given. And you can make some notes about that. So you need to know for PRNs, which one can I use for headache? Okay, which one's indicated for that? Which one's indicated for sleep? Because you see a lot of sleep medications, PRN sleep, or at bedtime as needed for sleep. Knowing that reason will allow you to figure out if it's working, and you can make some notations about it. If it's not working, then we want to know that. That's something to share with the prescriber. He gave him, you know, he said, take Tylenol, 650 milligrams every 6 hours for pain, and yet your consumer continues in pain, it's not working, then you need to let somebody know about that. Okay, we get a lot of questions on MARS, and facilities in general have their own form that they use. There are some standard forms, and Dr. Lazaro and I have worked on trying to come up with some example MARS that we can send if you need an example. But it needs to have these things on it. It needs to have obviously the drug and the strength, the number of dosage forms that make up the dose, 1 tablet, 2 tablets, whatever. Should have the prescriber on it. And there's a number of different prescribers out there, not just physicians. There can be nurse practitioners, physician assistants, and people. It should have the prescriber's name on there. What times, how many times a day, what times it's to be given, and how many times. And then any information on the auxiliary labels, I generally like to see put on the MAR. If this is something that is taken on an empty stomach, you set the timing up so that it's before a meal, and then you put on there before meals or whatever, so that that information is available to you on the MAR and not just on the bottle. One other thing I'd like to alert you about is some medications, consumers have trouble swallowing some medication. You and I have trouble swallowing some of these horse tablets that they give us, right? And so the thing that many of us will do is, break it in half or crush it. And there are pill splitters that you can buy in pharmacies. There's crushers and all kinds of things. So the real question is it okay to crush it? For many tablets, it is, but others it's not, particularly those that are extended release, and there's a number of names for that: extended release, delayed release, sustained release. There's a number of names for that stuff. If you have any questions, you have 2 options. Call the pharmacy. They'll be able to tell you if you can crush it or you can break the tablet in half. Second option is to go to the Institute for Safe Medication Practices, and that website is right down here. It's www.ismp.org, and they have what's called the Do Not Crush list. And you can look up the medication. If it's on the list, you can't crush it. If it's not on the list, you're almost sure that you can crush it. I think the best thing to do is call a pharmacy, because we know this stuff and we can tell you. We can also help you figure out how to, if it can't be crushed, we can talk about other options with you. One of the common things I've seen for consumers is they can't take their medication because it's too big, or they can't swallow, or they don't like it or whatever. And so they, people are trying to figure out, well, what am I going to do? What am I going to do? Send me a note or talk to your pharmacy. Actually, talking to the pharmacy may be better. These drugs come in different formulations. So for instance, if your patient can't swallow a risperidone tablet, there is a risperidone liquid. There's also some injectable formulations of some medications if they can't, swallow or something like that. So there are a number of different formulations that are out there. So if you have a consumer who's having trouble swallowing medications, talk to the pharmacy or get a hold of us and we can help you with that. Another thing to never do is use an unapproved abbreviation. Say what you have to say in writing. Don't come up with some new abbreviation that only you know about it. Make sure that your PRNs are not scheduled for administration. Those are only as needed, and they should be somewhere else on the MAR, separated from those that are scheduled, so that you don't accidentally give them a PRN when they don't have the reason for taking it. So always review the MAR before administration. Never set up and give medications without reviewing the MAR first. So the MAR has a place to put the date and the time that the med is given, and you follow your facility's policy. Generally, we will initial the time in the little box at the time where the medication is given. Some facilities, if the medication is refused or it's not given for whatever reason, their policy might be to circle that time and initial it and then write a brief reason why it wasn't given. But the thing that you want to make sure you don't do is you don't erase on official documents like MARS. If you make a mistake or something along those lines, a single cross through your initials and then why, what the error was, and then put the correct information on there is really what we do. For PRNs, again, documenting the reason it was given and the time. There are some medications that we have to do vital signs. So if you happen to have a patient who's taking the drug called digoxin, it's a heart medication. Sometimes the physician will say, hold the medication for pulse less than 60. Some blood pressure medications, they might say hold for blood pressures less than 100 over 60 or whatever figure they come up with. In those situations, you want to make sure that you take that vital sign before you give the medication. All right, let's talk about some just simple steps that you can take to be successful with your administrations. I'm an organized person. I drive some people crazy, but try to get everything together that you need. You don't want to be running around, got medication sitting here, but oops, oh, the medication cups are over there, and you walk away and leave the med, it disappears. All kinds of things can happen. So you want to be organized, get everything you need, set up your medications, make sure your MAR or medication log is accessible and you're using that. Today, especially, it's important to wash and dry your hands. Some facilities may even have you glove up. In the hospital, I personally don't ever handle a patient's medications without gloving up. And that's especially important today. But it's best if you cannot handle medications, and if you do, certainly at least wash and dry your hands. But if possible, if I'm going to touch something, I generally glove up. Prepare the dose. Some places use little paper cups to put the tablets and capsules in before they give it, and then run back through the 7 rights. So I got the right patient, is this the right drug and the right dose, etc. Just run through those questions in your mind. This is what I call foundational. I've been practicing pharmacy now for over 40 years, and there's just some foundational things that I continue to do that are simple. Anybody can remember to do them. It's not high-tech stuff, but it's this kind of things that the right person is the right drug. And I tend to be very careful and methodical when I'm handling medications in the hospital because it's easy to get used to what you're doing and it becomes routine. And when that happens, mistakes are very easy. So I have these kinds of things that I go over in my mind every time I'm handling a medication, and it's just become second nature to me. And that way I go home and sleep pretty well at night, knowing that the risk of my having made a serious mistake are really minimized. You want to make sure you watch the consumer and make sure they take their medications. There's a phenomenon that we call cheeking, where some people will take their medication, stick it in their cheek, say, thank you very much. They walk away, go to a trash can and spit it out. And so you'll see some patients who do that, particularly in my world of psychiatry. They do that all the time to us. So we have to watch and make sure that they actually took their medication. Then you document. Now, this is hugely important. You don't document ahead of time. You document following the administration. Because if you document and then something distracts you or whatever, and they don't take the medication, well, you've documented it, and then you forget to go make a correction, and the next person who comes on thinks the medication was given. So doing the correct documentation is really critical. Now, what do you do if your consumer refuses? Okay, it happens from time to time. And there's any number of reasons why a person might refuse to take a medication. With consumers, I think you have to investigate a little bit because they may or may not be able to communicate to you why. Well, maybe this thing tastes horrible. Okay, maybe they can't communicate that to you. Maybe they're in a bad mood. Maybe they're being sort of passive aggressive, or for whatever reason, they don't want to take it. Well, they have the right to do that. And there's only very limited situations, particularly in psychiatric units, where we can give medications against a person's will. And that is rare. And it's only in that kind of setting. You never give a consumer medication against his or her will because they have the right to refuse. And what that also means is you can't hide it in their food. You can't crush it up and put it in their applesauce. They have to know that the applesauce they're about to take has medication in it. So this is very critical that we understand that. We can't be sneaky on this. They have the right to refuse. Now, what happens if they do refuse? Well, talk to them. You know them better than anyone else. You're with them every day. Well, why are you refusing? And you can investigate a little bit. Well, yeah, this is upsetting my stomach. Okay, maybe I need to talk to the prescriber and see if there's something else that we can do for this person. Maybe, as I said, they don't like to take, maybe the tablet's too big for me to swallow. You can investigate this, but you should put the reason down on the MAR, when you circle the time and initial it, put the reason that they refused it. Now, if if they do refuse, it's okay to offer the drug again a little bit later, particularly if it's a behavioral kind of refusal. They're just in a bad mood, or they're mad at you, or whatever it is, and they're just being uncooperative. Then, maybe an hour later, offer the medication. And when you put that on the MAR, put the time on there and say given late because patient initially refused or whatever. But if refusals keep going, you need to let us know about it because they're not getting the medication that they need for their condition. So you want to let your care home administrator know about that, and the service coordinator, and probably should contact the physician if this stuff goes on. I see a lot of SIRs where medications have been refused, or what I call willful non-compliance on the part of the consumer, and these phone calls are made, and usually they say, okay, no big deal, just try and give it at the next time of administration and go from there. But certainly, if these folks are refusing medications, you need to let the prescriber know about it. Now, just a few tips, just things to keep in mind that'll kind of keep you on the straight and narrow. Never ever use a medication from an unlabeled bottle, or if you can't read the label, if it's gotten smudged and you can't tell what it is or whatever, if you don't know exactly what it is, don't give it. If you open up a bottle and you find more than one medication in there, which I see all the time, we do brown bag reviews for patients at times to counsel on meds. I'll open up a bottle, oh wow, there's some blue tablets, there's some pink tablets, there's some green tablets, so what's going on here? I was on an airplane this last week, and I did see a person pull out a prescription bottle, and I saw her pour 3 or 4 different medications out of that same bottle. Okay, that's risky business. She probably knew what she was taking, but I recommend that you don't do that, and I recommend that if you want to move your meds, get one of those little med pack things, those little Monday through Friday things. Some of them are in little cute little kits, and you can put your tablets in there. But for consumers, we don't want to do that. We want that in the prescription bottle, and we want it compared to the medication administration record. Physicians should notify you and let you know when they're changing the dose or they're changing the medication. There needs to be clear communication between care providers and prescribers on what is being given and what's not going to be given anymore. Make sure you follow up on that stuff. Always follow the auxiliary label indication, things to do that are on that bottle. Shake well, take on an empty stomach, store in the refrigerator. There are a number of labels that we put on that bottle, and they're there for a reason. You should know the name of the drugs you're given. What is it? And then always check those refills. Again, one of the most common SIRs I get will be because a consumer didn't get his refill. And often the pharmacy gets blamed for it, but I can tell you that often it is not the pharmacy. We can't call physicians, we hardly can't call physicians' offices anymore. They want everything by fax or electronically. And we don't know what's happening on the other end at their office, but I can tell you from personal experience, sometimes they're not very quick to tell me if I can refill a medication. So it's not always the pharmacy. One other thing that I really didn't put on here is if you have a consumer who got a stable set of medications and chronic and they're going to be refilled, you can check with your pharmacy and see if they have an auto refill program. Many pharmacies do. And when it's time to refill, they'll do it. And sometimes if they have delivery service, they'll even deliver it. So for instance, I'm at my own pharmacy. For my medications, the people who fill my prescriptions have me on auto refill. And I get a text about 2 or 3 or 4 days before I'm running out of medication. Hey, Bill, we've got your prescription ready. I go pick it up, but they also have a delivery service. So you can investigate these auto refill programs. They can be very cool for consumers that have issues in getting these refills. Lastly, when you get a new refill for a person, always check it against what they were taking. And if there's any differences, you need to investigate that. Does it now say 2 tablets instead of 1 tablet? So if there are any differences in what you get from the pharmacy and what you've been giving, make sure you clarify that before you move forward. Always check labels for expiration dates. People ask me a lot, what's in an expiration date? Well, let me tell you how that works. When manufacturers make medications, they're stable, but they're eventually going to break down just like everything else. And so the expiration date, when it comes, I buy medications in the hospital pharmacy. I get the bottle, it comes and has an expiration date on it. And that date is determined by the manufacturer. And what that date guarantees me is that at least 90% of the stated potency of that drug remains until that date. After that, it might be less than 90% of that stated potency, so you're not getting enough medication to do the job. So that's what's in an expiration date. And there's almost no medications that when they expire, they're going to harm you in terms of poisoning you or something. It's always that you're not going to get the right amount of drug because it's degraded to the point where you're not actually getting, if it's a 10 milligram tablet, beyond the expiration date, we can't guarantee that you're actually getting 9 milligrams of medication. So always remember to check those expiration dates. Pharmacies will almost never send you what we call a short dated prescription, one that's going to go out of date in 6 months. They almost never do that. They almost always have at least a year on those expiration dates. Always, again, going through the rights of administration, know your consumers' allergies. Again, they may be seeing multiple prescribers, and people are notorious for not telling us all their different allergies. And all of a sudden we give something, and I've had this happen to me with patients in my hospital where they didn't tell us. For instance, I had one patient didn't tell us that he was allergic to ibuprofen, and that's a standard drug for us to use for pain. Gave him ibuprofen, had a reaction we had to deal with, and he just simply forgot to tell us. So you want to know what your consumers' allergies are. Keep a reference source. I'm going to tell you about two in just a moment. You can do hard copy books, or actually I use my phone all the time, frankly. Most people have smartphones now, but you can use your computer. So that takes me to where can you get good drug information? Now, you know as well as I do, the internet is full of a lot of junk, stuff that you simply can't trust because anybody can go on there and pretend to be an expert. You got to be really careful about this stuff. So I'm giving you three here that I think are good. Two are online sites, Daily Med and Medline Plus. Those are from the federal government, CDC and NIH. And those are very reputable and they're very consumer friendly. You can just Google up Daily Med, or you can Google up Medline Plus, go to their website and you can bookmark it. And particularly Medline Plus, you can learn about diseases, all kinds of stuff you can learn about there, but you can also put in a drug name and boom, up pops a lot of information. So I use those all, they're bookmarked on my computer, but they're very consumer friendly. Daily Med and Medline Plus. Or on your smartphone, go to the App Store and you can look up Epocrates. And I spelled it out here. It's kind of hard for people to catch. It's Epocrates, Epocrates. There's a free version, and then of course, like all apps, you can upgrade and pay some money if you want some more things. I would recommend, just for what you need, just get the free version, put it on your smartphone, and you can pop any drug name in there that you want, and boom, up comes information. Two very reputable online sites, and then one very reputable app. I use those myself. Now, what about storage? Again, this is a very important thing to ensure that our medications don't degrade. But also there are security issues. So your medication cabinet really should be locked at all times, except when you're giving medications. And only authorized staff should have access to those medications. And I want to say here a word about controlled substances. Your facility should have policies on how controlled substances are handled. You don't want those things walking away. You don't want one for you, one for me kind of stuff going on with controlled substances. And I know that all of our care providers are not going to engage in that, but sometimes other people can come in. I've actually had Vicodin taken out of my home, okay? And that's one of the things you have to be very, very cautious about. So you should lock these cabinets, and you should have policies about what to do about controlled substances. Perhaps occasionally you want to count them with two people. And then you compare the amount left to the amount that have been documented on the medication administration record. This is just good practice to protect yourself. I know in the hospital, I'm a pretty good pharmacist. I've been practicing for a long time. I have no idea how to walk out of that hospital with a stolen controlled substance. We have so many safeguards in place, but then that makes me feel pretty good because nobody can accuse me of taking one of those things. So make sure you have some, procedure around controlled substances where you safeguard them from having some disappear. And then you want to make sure that medications that have to be refrigerated are stored in a refrigerator at proper temperature, and that will be stated on that auxiliary label. And they should be in a separate locked container. I realize most places are probably not going to have a separate medication refrigerator. Optimal would be that you do that. But if you don't, then at least have them in a separate locked container in the refrigerator, preferably somewhere in the middle of the refrigerator. That's where the temperature is most constant. I generally try to separate oral medications from external medications. In fact, we do that in pharmacies. We are required to have those types of formulations separated so that we can't make a mistake. There's some liquids, for instance. I remember when I was an intern in San Francisco quite a while ago, I came into the pharmacy one day and the pharmacist was fit to be tied because a person, there are two people came in, one with scabies, one with some cough. And so one was getting cough syrup, one was getting Lindane lotion, which is highly toxic. And he got those prescriptions mixed up. When the woman with the cough walked out with Lindane, and she wouldn't know other than it tasted horrible, but it was a liquid preparation. And so fortunately we were able to track her down before she took any of that because it was a really toxic stuff. But it was 2 amber bottles filled with a liquid, one internal, one external. So I generally recommend that drugs that are intended for external use, or somehow maybe they're in a baggie or they're set separately in the little container, but just so that you don't get those things mixed up and give somebody something orally that they should have only applied topically. Always keep medications in their original container. You're not a pharmacist. Don't start relabeling things. Don't put them in anything that's unlabeled. There is one exception to that. If a consumer is going to need 1 dose of a medication, they're going to a day program or something, or you 1 dose, you can take an envelope and you can put all that information on the envelope, put the 1 dose in there and seal it up. But another option is sometimes pharmacies will prepare another prescription container for you with a label that's properly labeled, and you can transport meds like that. So don't ever get into the habit of relabeling medications. Now, another thing that comes up a lot is, well, what do I do with expired medications? Okay, so we don't put those down the sink. And there are now, fortunately, there's 2 take-back programs. One is the DEA occasionally will have take-back programs for controlled substances like the Vicodins and Norcos. The idea there is to pull as many of these out of circulation as we can when they're not being used anymore. Back in the day, you might go in for a tooth extraction or whatever, having a baby, having minor surgery, and you come home with a prescription with 30 tablets of Norco, and you only take 2. Well, what do you do with the rest? Most of us put it in the cabinet and say, if I hurt myself down the road, I'll take a little bit of Norco. But that's one of the things that has opened the door for people to walk into your house and walk out with some Norco. So the DEA has take-back programs. You'll see those advertised in the newspaper and on the news programs, and you can take your stuff down there and they will take it back for free. The second thing that's happening, and I really think this is cool, some pharmacies, for instance, Walgreens, I think maybe some others, but I know Walgreens has a goal of having every one of their pharmacies be able to do this. If they're not already, then in the near future. They will take back medications and they'll send them off for destruction. Why do I think this is really cool? Because you know what? It costs us to send medications out for destruction. It's not a free thing. Somebody has to pay that bill. So I'm pretty proud that Walgreens has stepped up. There may be other pharmacies, maybe your pharmacy does it. But another thing that you can do, if you just have a few things, they're not controlled substances, maybe, your oral medications can be put into a container, like with wet coffee grounds. I probably wouldn't use cat litter, but you can put in there some moist cat litter in a baggie, seal it up, and then you can put that in the trash. Now, that sounds bizarre, doesn't it? But in fact, you can look up on the FDA website and the EPA and find that there are medications that you can do that with, and that's most medications. There are some that you can actually put down the toilet. For a while, we wouldn't flush. We flushed everything, and then we went to this place where we flushed nothing. now there's some things. So the best thing to do is go to the FDA website, just www.fda.gov, and look up drug destruction, and you can find these things to do it. Now, in your facility, make sure that you record the destruction of medications. Okay, there should be a log that you record that stuff on, so that where it goes is documented. I do that in my pharmacy at the hospital. If I'm destroying medications or sending them out for destruction, I record that so that there's a record of where they went. So I know I kind of rushed through this a little bit, but this is part one. We'll be doing part two next month. And so now what I'd like to do is give this back to Claire. And Claire, I'm going to let you see if you can moderate some questions. I think I'm going to stop sharing my screen. Okay, so I have Claire back in front of me. Are there any questions?
Hi, guys.
Answer?
Yeah, so for those who have any questions, please put them on the chat or on the Q&A portion. I've been replying to the individuals who have typed in something in the chat as I go along. In the Q&A, there was one question here that I wasn't really sure. I don't think I answered it really well. They were asking Dr. Kehoe how many items or how many questions are on the test. I told them it's a single page test, but I don't know how many items there are.
It takes you like 5 minutes.
What?
I'm sorry, there is a background noise. I apologize for that. My daughter is having distance learning.
Oh, I know all about that because my grandkids just left here. We're doing that too. All right. Look, on these quizzes, I make them very straightforward, okay? And I generally try to have 5 to 7 questions. And you can trust me. If you've ever come to one of my live programs, I'm actually better live, trust me. But in my live programs, I actually will review the questions with the participants and give them any help that they need. There's nothing here to try and be punitive about it. And again, remember, if you want to jot down my email, it's pharmacist@vmrc.net. If you have any questions about my quiz questions, you can always send me an email. I check my VMRC email probably every 2 or 3 days. And so just send it and I'll answer your questions and then you can send it in. But I generally put about 5 to 7 questions.
Okay, there was just another question at the Q&A that I just answered, asking where we can access the recording. So I told them we are going to post a recording of this webinar at our website and at our Facebook page.
Okay.
And for those who want to have CE after they've watched the recording, they just need to contact Lorraine. And Lorraine, I'll let you tell them your email.
You're muted.
Oh, you have to unmute.
Sorry, I did it again. I have a little one too. It's alrodriguez@vmrc.net. And just email me for the quiz and send me your email address so I can send it to each individual. And then you can send it right back. And as soon as I get a chance, I will send you the certificate. It'll be sometime next week because we have a lot of you, but I will do it as soon as I can.
Thank you.
Okay, thank you, Lorraine. So we do have some questions here coming up in the chat now. From Brooke, if we do not get prescriptions from Walgreens, can we still bring them to Walgreens?
My understanding on that is yes. I looked it up on their website. I didn't see anything that said it was specifically for Walgreens prescriptions. I don't want to speak for them definitively, but for instance, if I had some right now, I would probably feel free to run down there and see if they would take them back. But don't forget too, if you don't have like a boatload of things, if you just, will do that baggy thing, I like to use wet coffee grounds. It says in the directions on that on the website that you don't have to dampen those things. The reason I dampen them is it will certainly destroy those dosage forms. If it's dry, I could, even if it's like cat litter, I could still see some people pulling it out and taking it. So I generally use wet coffee grounds, and I do this with my stuff all the time. I just put in a baggie, take today's coffee grounds, put them in there, and I put my stuff in there, and I seal it up. There's some things, as I said, that you can, certain types of narcotics, you can actually, believe it or not, flush. But there is a list at the FDA, things that can be flushed and things that have to be destroyed with the baggie thing. And it's easy to get a hold of. It's www.fda.gov, and then you would look up drug destruction or something along those lines.
Okay, I was just replying to Thomasina. Thomasina is asking to send the quiz. So Thomasina, I wrote here in the chat Lorraine's email, so please email her to get the quiz. Those of you who are asking if you can just send your email address on this chat, please don't. We would prefer that you send it directly to Lorraine, because this chat, once our recording is done, the chat is actually not being recorded by Zoom. So it will disappear and we will not have any copy of that. We have another question here. How do you figure out the time interval? For example, 3 times a day is every 6 hours. Is that right?
No, 3 times a day, if you wanted to space it exactly apart, would be every 8 hours. But again, there's 2 ways a prescriber will tell us about 3 times a day. One, they might write the prescription, say take one or take 1 tablet 3 times a day. If you've ever tried to read a prescription, that may often be 1 TID. We're trying to move away from those abbreviations and write these things out. But if he says 1 3 times a day, we usually take that to mean that it should be about 8 hours apart, but time is not necessarily critical. If he wanted it to be right at 8 hours, he would say take 1 tablet every 8 hours. So what we do in the hospital actually is we have 2 sets of time frames, let's say for 3 times a day. We might, if the order says take, give 25 milligrams 3 times a day, then we might give it, at 7 a.m. and maybe sometime around 2 or 3 o'clock in the afternoon, then probably at bedtime. Probably not going to wake them up. But if it says every 8 hours, we might give it at 7, 3, and 11. You follow me on that? So generally, we take our cue from what the physician is saying. If they just say 3 times, 4 times, 2 times, we're saying ballpark it. Roughly divide the day by that number. Roughly, if it's twice a day, then every 12 hours. But if they want it exactly, they will say take it every 12 hours. That's just a general rule of thumb that we follow.
Okay, thank you. We have another question. What do you think about the liquid pill destruction chemical that we can buy on Amazon to destroy the meds at the facility?
I have to be honest with you. I'm not familiar with it. I haven't seen that. I'm not sure why it would
I haven't
be.
either.
I haven't seen that. It's something that somebody came up with. I'll be honest with you. I probably, well, I don't want to get sued or anything here. I don't think it's necessary because I trust the EPA, the Environmental Protection, whatever, and the FDA, Food and Drug Administration, and they have collaborated on this, and they have these directions that you can follow. And they have 2 lists. Here's stuff you can flush, and here's stuff that you can't flush, but here's what you do. You can put it in with coffee grounds, cat litter. They list a couple of other things, and then put it in your garbage. I mean, I'm probably not going to worry about chemical destruction with other chemicals. I don't know. It just doesn't make sense to me.
And for those who are asking for a Facebook page, I just posted the Facebook page of VMRC on the chat button. I have another question here for those who don't have Facebook page or Facebook account. How can they access the webinar? So as I've mentioned, it will also be posted on VMRC website. So that's another way of accessing the webinar. Another question here, because consumers have the right to refuse, how does that affect cheeking monitoring?
Affect what?
Cheeking. When they're cheeking it, how does that affect them monitoring patients when they're cheeking it?
Well, how can you tell? It's very hard to tell. I know in the hospital, we ask people to open their mouth and take a look and see if it's still sitting there. But to be totally frank with you, if they've got it stuck under their tongue or something along those lines, we're not doing finger sweeps or anything like that. We might just ask them to open their mouth. So there's no real surefire way. You have to kind of follow your intuition on that, because generally they'll walk away. Maybe they go near a trash can or something along those lines. But generally what we do in the hospital, and I would assume we could do this in a residential site, just ask them, can I see in your mouth? Make sure that went down. You don't have to accuse them of anything. Just, can I see if that got stuck or if it, went down or not? And then take a look at their mouth. You can't go poking around, But then you record on, if you find that they did do this, or you saw them spit it out, or you go in your room, in their room, and you find this stuff like on the floor, this happens a lot. Then go back and document that on the MAR, and then you want to tell your colleagues too that this is happening so that everybody's watching out for it.
Sounds good. There is from Teresa, she's sharing here that you can also take old prescription to the sheriff's department and the staff police department. They have prescription drop boxes.
Oh, great.
And then, yeah, and then from Julianne, she said Kaiser has a box in the pharmacy for med disposal for anyone. So that's good.
Yeah, there's been a big push on this, particularly with the opioid epidemic, because honestly, one of the things that has facilitated what we call prescription drug abuse is that a lot of us were getting these prescriptions, go to the dentist and have a tooth pulled or whatever. A lot of us were getting these prescriptions, and in the day, you almost never filled a Norco prescription for less than 30 tablets. And I know when I had my own surgery a few years ago, I think I got 30 tablets, and I probably used 1 or 2. And then it sits around, and people come in, and they came into my house. It was a nurse who had a problem and went out with some of that Vicodin. So agencies now have really kind of stepped up to the plate so that we can take those things in. It really is recommended that we not, store these things up for the rainy day when you need Narco. It's really recommended that you take it in. It really pleases me to hear that Kaiser and sheriff's departments are stepping up to the plate.
That's true. I don't see any other questions here. I do see a few people have put in the chat button their email addresses, so I'll have Lorraine copy that, because once our webinar is done, we will not have any copy of this as well, so that they could have credit. I think they wanted to have a quiz for their Cs.
Okay.
Checking the question and answer button here, I don't see any other questions. So if you guys don't have any other questions, again, please email Lorraine Rodriguez at vmrc.net for the quiz. I'm gonna copy and paste again her email address at the chat, so you guys will have access to that. Please email her so she can send you back the quiz and you guys can claim the CEs. Again, the webinar recording will be posted at the VMRC website and also at the Facebook page of VMRC. So if you guys don't have any Facebook account, it's also going to be on our VMRC website, and it's www.vmrc.net. Okay, thanks, Dr. from Marika. She loved your presentation.
Well, thank you. So am I going to become a Zoom star?
Yeah, you're going to be. We really appreciate all the attendees. We have over 100. A while ago, at the most we've had was 123 participants.
Okay.
So that's really a lot. Really positive feedback.
So well, everybody come back next month for part 2.
Yes. Yes, I've already got questions of people asking, how do we pre-register for the part 2? They're already interested. So we're going to post the link to that in our website as well. And we're going to post it also on our Facebook page. So watch out for that. And I'm going to ask Doug also to post it in our other social media sites. I know we have a LinkedIn account as well. And I think V. Marcy also has a Twitter account. So I'll have him post on our other social media accounts. We're trying to be very active in the social media. That's our times right now. We have a lot of people here saying thank you. Kesher, Candice, Iris, La Familia residents, so Doris. So thank you all for coming. We really appreciate it. Thank you, Dr. Kehoe. Thank you, Lorraine.
Have a good weekend and stay safe, everyone.
Okay. Thank you, guys.
all.
Bye-bye.
Bye.